Hello, my name is Brooke Robichaud. Today I'm going to be talking about pulmonary hypertension. I work in the cardiac ICU as a registered nurse, so I take care of this patient population pretty frequently, and I see how fatal it is for the patients and their family members. Pulmonary hypertension can be defined as high blood pressures in the pulmonary arteries. The pulmonary arteries are responsible for carrying oxygen-poor blood from the heart to the lungs. In the image below, you can see a normal pulmonary artery pressure is 25/10. In this population of patients, we can see pulmonary artery pressures that are similar to systemic blood pressures. Pulmonary hypertension is classified among 5 groups based on its cause. Group 1 is often idiopathic. It's pretty rare, just related to lessened blood flow through the pulmonary arteries, which causes stiffening and narrowing, thus increasing the pressures. Group 2 is our most common type of pulmonary hypertension. It's due to left-sided heart disease, since the left side of your heart is responsible for pumping blood to your entire body. Anytime that blood begins backing up, you're going to see strain on the right side of the heart as well. Another common type of pulmonary hypertension we see is due to lung disease or hypoxia, so different diseases such as asthma and COPD can constrict the pulmonary arteries and raise the pressures. Group 4 is a little bit more rare due to lung blockages. Blockages such as clots or scarring can stress the right side of the heart and cause blood flow to be disrupted to the lungs. Group 5, also pretty rare due to other disorders, typically hematological or systemic, and can cause that pulmonary artery hypertension as well. The pathophysiology of pulmonary hypertension is characterized by several key markers, the first being inflammation. With inflammation, we see immune cell accumulation and vascular remodeling. Examples of inflammation that causes pulmonary hypertension can be from autoimmune or connective tissue disease such as scleroderma. As far as metabolic imbalances, we see mitochondrial shift from phosphorylation to glycolytic pathway, which also then causes the pulmonary hypertension to progress. In relation to genetic and epigenetic abnormalities, we see DNA methylation, we see histone modification and non-coding RNA. We see impaired angiogenesis, which is the formation of new blood vessels, and we see right ventricle abnormalities such as hypertrophy, dilation, and dysfunctioning, which thus causes uncoupling of the RV and the pulmonary vasculature. With pulmonary hypertension, we also see increase in pulmonary vascular resistance, which is the resistance against blood flow from the pulmonary veins to the left atrium. We see dysfunction in the endothelial cells, and then again that right ventricle, hypertrophy, dilation, thus causing the uncoupling in the pulmonary revasculature. This is an image to show the pathophysiology of group 1 pulmonary hypertension. Causes and risk factors of pulmonary hypertension are determined by the group that they are classified within. Group 1 is reserved for those idiopathic reasons. Often we see congenital heart disease, medication toxicity or medication induced, and then other diseases such as HIV, liver, scleroderma, portal hypertension, things like that. Group 2 we see related to those left-sided heart disease, so any valve, aortic or mitral valve disease, left-sided heart failure, or ventricular hypertrophy. Group 3 is related to those lung diseases, so that COPD, that interstitial lung disease, and that OSA. Group 4 related to those lung blockages, so a pulmonary embolism, things like that. Group 5 related to those metabolic and hematological disorders, so the kidneys, thyroid, sarcoid, metabolic, things like that. Patients with pulmonary hypertension often have very acute signs and symptoms, biggest being shortness of breath. You'll see a lot of cyanosis associated with this, which is blue or dusky appearance of the skin, And you'll see chest pain, you'll see increased swelling in the peripherals, as well as the abdomen, fatigue, dizziness. It's really unpleasant. Patients are very symptomatic. As far as treatment goes for pulmonary hypertension, as I mentioned previously, there isn't a cure. It is not reversible. So treatment is typically based on treating the underlying condition and managing symptoms. Calcium channel blockers are a great resource because they'll decrease systemic blood pressure as well as pulmonary artery pressure. Diuretics, as I mentioned before, patients often will have peripheral edema as well as edema in their abdomen. So keeping them relatively dry to help support their heart and the way that they feel. Most typically, I think when we think of pulmonary hypertension, we think of the pulmonary vasodilators, which work on relaxing the arteries to improve blood flow and decrease the strain on the heart. A lot of times these pulmonary vasodilators, patients go home on, they have long-term IV access, and they are hooked up to an IV medication for the rest of their life. Some of the pulmonary vasodilators are also available as inhalants. It's kind of all depending on which group you're classified under. Most patients with pulmonary hypertension end up requiring oxygen therapy. Typically, they're not able to oxygenate well enough on their own, so they'll have supplemental. And then, as I had mentioned before, treating the underlying conditions, which will aid in symptom management and decrease the progression of the pulmonary hypertension as well. As I previously mentioned, there isn't much treatment for pulmonary hypertension. Right now, we're kind of just treating underlying conditions and symptom management. But a study conducted in 2023 at UC Davis under the Goncharova lab looked at treatments aimed at selectively killing the modified smooth muscle that occurs in the pulmonary arteries with pulmonary hypertension. And they were actually able to reverse some of the hypertension. It was discovered that TSC2, which is a growth suppressor, was nearly absent in the smooth muscle cells in the pulmonary arteries in patients with pulmonary hypertension. They noticed when they returned the growth suppressor that the arteries had the potential to return to their biological level. And then, so they supplemented in rodents a growth suppressor or a medication that aided in growth suppression called SRT-2104, which improved lung function and reduced pulmonary hypertension in the rodents. So that's really exciting, really optimistic for this field of patients and this population of patients that typically kind of just suffer. So it's really exciting. As I had mentioned before, it's a really devastating disease, really hard on the patients and their families. So any advancement is a win. As I mentioned before, right now our treatment options are very limited. So any advancement in the field of pulmonary hypertension is exciting and beneficial to this population of very vulnerable patients. I hope you all enjoyed learning about pulmonary hypertension as much as I do, and hopefully there continues to be more advancement in the field and we can continue to help more patients and their families affected by this terrible, terrible condition. Thanks.